All right. Hello, everybody. My name is Hawke, and I'd like to welcome you all to this webinar today. The webinar today is called Staying Connected, Using Telehealth to Advance Addiction Treatment During COVID-19. Today we'll be covering a few different topics that are related to the title. So we will review both telehealth policy changes that have occurred due to the pandemic, and also the implications of those changes for provision of addiction treatment. We'll also talk a little bit about some practical challenges that are specific to treatment and conclude with some recommendations for a variety of different stakeholders. As I said before, I'm Hawke, and I'll be moderating today's session. I am an informaticist at RTI International, and I lead our virtual care portfolio. I've also done a number of different types of studies related to substance use and misuse. And joining me today is Julie Saavedra. Julie?
Sure. Hi, I'm Julie Saavedra. I'm the Director of Behavioral Health Epidemiology and Treatment Research Program at RTI. My work focuses on the evaluation of publicly funded health and behavioral health services, and my primary focus is on the development of quality measures to improve health and behavioral health outcomes. I'd like to turn it over to my colleague, Lisette, to introduce herself.
Hi, everyone. I'm Lisette Saavedra. I'm a research psychologist working in the arena of mental health services research. I have specific expertise in the assessment and treatment of anxiety, PTSD, alcohol, and other use disorders. I have experience delivering interventions one-on-one and in group settings. And related to our webinar today, for the last 2 years, I've been working in the telehealth space, working with wonderful colleagues focused on development and delivery of interventions for trauma-exposed victims of crime and also in the addictions.
Thank you. So today we all work at RTI International, which is a nonprofit research institute, and RTI is sponsoring the webinar today. In terms of questions, you can submit a question in the bottom left of your screen at any time during the presentation, and we will answer questions at the end. We also have a few resources. So if you look under the headshot image on the left of your screen, you can see a PDF of the presentation that you can download, and also some additional resources. And that is the end of my knowledge on those two things. So Melissa Pingera can help you if you need some assistance if the chat isn't working, and her email is there. And then there's also some information here about credits. So if you have to stay on the whole way through and don't leave the console, and at the end there'll be a slide with further instructions on receiving continuing education credits. So now that we've gotten that housekeeping out of the way, let's get into some of the substance. So before we go ahead and talk about telehealth, I just wanted to see who we have here in the room. So I'm going to send, or a virtual room, I suppose, I'll send a survey out. So if you could just check the box that works kind of the best for you. So where are, let's kind of see who we have here. Are you from a provider, a health plan, a government organization, a research organization, or something else? So I'll just give you all a moment to go ahead and complete the survey. It's just helpful for us to have a sense of who we have joining us today. Oh, it looks like we have a nice mix. So we have probably the most from providers, but we also have some folks from government organizations. Other is actually pretty high, and then research and health plans. Great. Well, thank you for completing the survey. I'll go ahead and end that and move back to the slides. So first, I'll talk a little bit about what telehealth is and how it can be used. Now, it might seem like telehealth has been everywhere, so why do we need to define it? Well, much like many other terms, there are a number of different ways that people think of telehealth. So it can be considered, sometimes people call it telemedicine or digital care or virtual care. Regardless of what you call it, it involves interactive electronic exchange of information, and it involves several uses: the diagnosis, treatment, support, and also care management. So telehealth goes beyond just one type of use case to a variety of different types of uses. And telehealth can also address several barriers. So oftentimes there are barriers to access to care that could be due to geographic location, perhaps availability of transportation, that sort of thing. So there's a number of different ways in which telehealth can improve access. Also, for people who are in rural areas, if they perhaps are isolated from population centers, or perhaps they don't have access to transportation, they might live miles away from care that they need. Or maybe there are seasonal changes in access. So for example, in many ski towns, there is greater access in the winter during ski season than not, and similarly with beach towns. So telehealth can help address that barrier. And then also workforce challenges. There is a shortage of behavioral health providers generally, and particularly in rural areas. So by using telehealth, that can help obviate some of the challenges related to workforce. So I covered a little bit of this already, but just to have a short overview. So telehealth can be used in a variety of ways. So it can be used for documentation or data storage. It can help facilitate data analysis. So by gathering data from remote data generation items, communication and remote consultation, devices. So devices could be things like continuous glucose monitors or cardiomems, things like that. And then modeling and virtual reality. So all of those are different kind of pieces that can be part of a telehealth visit. And telehealth can be used both to support patient-to-provider care and provider-to-provider interaction. And so on the patient-to-provider side, for live visits, telehealth can be used for virtual visits, for patient-to-provider, or for e-consults, so electronic consultations between different types of providers. That could be primary care, specialty care, or it could be different types of specialty care, or whatever the case might be. In terms of remote patient monitoring, certainly there is patient-generated health data with wearables, if you're wearing a Fitbit or similar, but also sensors. And then for provider-to-provider, oftentimes device information can be used to support the e-consultation. Now asynchronous, which means not at the same time, data can also be used for telehealth. So in terms of sharing log data for patient to provider, so for example, if people are maintaining a journal of their feelings, or perhaps on the medical side, if they're maintaining blood sugar readings, something like that, that could be shared with their provider. Also for provider to provider, one provider can amalgamate a number of different pieces of information and use that to support an asynchronous second opinion consult. And then finally, mHealth, which really involves a lot of apps. So it involves apps, web-based communication, etc. So on the patient to provider side, that can support messaging or interaction. So for example, sometimes between support groups, there's a mechanism to message. On the provider to provider side, that can be used for education and interaction. And an example there might be something like a case review, or perhaps even a Project Echo type model, which involves building local capacity. So those are some ways in which telehealth has been and can be used. So now I know that there's been a lot in the news about policies that have changed in response to the pandemic, and so I'll take a few moments and summarize some of those changes. Traditionally, some of the barriers to greater telehealth uptake have been in these areas: reimbursement, licensing, technology, and prescribing. First, I'll cover reimbursement. So reimbursement is one of the biggest areas because without reimbursement, it's difficult to find the impetus for implementing and using telehealth. And so for the pandemic, in order to promote physical distancing, CMS has expanded reimbursement for telehealth services. And some of those changes include payment parity between telehealth and face-to-face visits, no originating site distinction, and what that means is that previously providers or patients could not be located at home, they had to be in a facility, But now, due to the pandemic, those restrictions have been lifted. Also, expansion of services that can be reimbursable for telehealth, and an expansion of provider types that can be reimbursed for telehealth services. Now, while private payers and Medicaid programs vary, many of them have followed suit, and as a result, there's been expanded reimbursement for telehealth during the duration of the pandemic. Another barrier is licensing. So traditionally, providers need to be licensed where the patient is located. So for example, if a patient and a provider are in different states, if those states border before the pandemic, the patient could travel to where the provider is located. However, after the pandemic, that is not true. So as a result, many states have increased their participation in interstate compacts. And what that means is that states have participated in groupings where they agree to allow one license to apply across states. And this, some states have said that this would be for the duration of the pandemic, and other states have indicated this is indefinite, so that remains to be seen. Another barrier is technology. Everyone knows about HIPAA, but what people aren't as familiar with is that some of the security provisions involve different types of technology. So what that means is that patient-facing technologies, so things like FaceTime or Skype or Google Hangouts, are typically not allowed to be used for a healthcare visit. However, because of the pandemic and because of the need to get people up and running with telehealth, during the pandemic, the Office of Civil Rights, which is who oversees HIPAA implementation, has allowed for patient-facing technology. So you don't have to necessarily use the type of security that you need normally. Also, the FCC has funded grants to expand broadband access and connectivity. And so what that means is that places that don't have access and connectivity in the United States have a little bit more support. And then finally, prescribing. So prescribing is an area in which there have been quite a few regulations, particularly with respect to controlled substances, which is of interest for MAT, medication-assisted treatment. In response to the pandemic, there have been a couple of changes to note. One is that the DEA has announced that they're going to have enforcement discretion for buprenorphine. So that means that telehealth can be used for that without an in-person exam. And then the other is that patients do not necessarily need to be in a DEA-registered facility or in the physical presence of a DEA-registered provider. And so those are changes that are designed to expand access. Now, it's important to note that for all four of these categories, the changes are expected, and all the agencies have said that the changes are for the duration of the pandemic. It is not clear, and I don't know that we've been given many indications about whether or not some, all, or none of those changes will be retained. So that will be something that we'll want to keep an eye on to look at all of these policies and all of these changes and see if those decisions that have been made will be extended or not, and to what degree. So now that I've provided a little bit of an overview, I'll turn it over to my colleague, Julie. And Julie Saavedra will talk a little bit about the implications for behavioral health more specifically. Julie?
Thanks, Sarah. Really appreciate that. So as we all know, COVID-19 is putting a tremendous strain on the public health system and also the public behavioral health system as well. As we know, individuals with behavioral health diagnoses face unique problems in accessing care during the pandemic. And I wanted to take some time to review the implications of providing care during COVID-19, review how states are responding by changing their telehealth, behavioral health policies, and to identify some best practices and perhaps some next steps. So before we begin, I'd like to ask you all a question. I'm going to release a polling question, and I want to have an idea of whether you've implemented telehealth for addiction treatment or behavioral health in your organization. Sending that out now. so far I have one person who's responded. Okay, it's updated. So I think we've given enough time, and it looks like the majority of people who are on the line have implemented telehealth for treatment in their organization. It's working well. We have some, probably less than 8%, that it's not been working very well. Some folks are planning on it, and some are interested in learning more about it. Thank you so much. So we'll go back to the presentation now. So telehealth policies have historically focused on health care provided by physicians and don't encompass the range of evidence-based care required to teach behavioral health diagnoses. Services such as supported employment, peer support services, and assertive community treatment are effective treatment modalities, but traditionally have not been widely supported as reimbursable telehealth services. Although telehealth is a growing body of evidence in many areas of healthcare, the evidence for behavioral health care and particularly addiction treatment has been limited. There have been some recent reviews of the effectiveness of telemedicine for treating substance use disorder. In 2011, Young conducted a review of the effectiveness of telemedicine in treating substance use disorder and found that about 60% of the studies supported telemedicine interventions. However, the studies did report that there were persistent challenges in sustaining participation. The review also showed a high degree of satisfaction on the part of participants, citing that about 76% of the studies indicated that participants were very supportive of telemedicine. In another study, Lynn and colleagues conducted a review of telemedicine interventions for treatment of nicotine, alcohol, and opioid use disorders. They found that studies suggested telemedicine interventions were associated with high patient satisfaction and were an effective alternative to traditional treatment, especially when access to treatment was otherwise limited. However, they cited substantial methodological limitations in the studies reviewed and called for larger-scale randomized studies that examined different models of telemedicine. They were particularly interested in telehealth options that could be integrated into existing healthcare delivery settings to increase the use of effective treatment for individuals with substance use disorder. So while the evidence is growing, additional research is needed. Another issue that's unique to the provision of behavioral health services through telehealth is the added concerns about confidentiality. Confidentiality laws associated with provision of behavioral health care, particularly addiction treatment, can cause confusion about the provision of treatment using telehealth. As the providers that are on the line are very well aware, 42 CFR Part 2 prohibits the use and disclosure of patient identifying information for individuals with substance use disorder without written consent. And due to social distancing, providers may not be able to obtain written patient consent for disclosure. SAMHSA has provided guidance that providers can use the existing medical emergency exception and have emphasized that providers make their own determinations whether a bona fide medical emergency exists for the purposes of providing needed treatment to patients. The confidential nature of behavioral health treatment can also cause individuals to avoid seeking care. Lizette's going to talk about that a bit later, but I just want to emphasize that sheltering in place with roommates and family members and houses and apartments that seemingly get smaller and smaller every day can make it very difficult for individuals to feel like they have the privacy needed for effective treatment. Another issue that's specific to behavioral health is that social distancing can exacerbate existing behavioral health conditions or be associated with new clinically significant behavioral health conditions. Prior to the introduction of COVID-19, there was already an existing behavioral health epidemic in the United States. And data showed that in 2018, over 19 million adults aged 18 or over had a substance use disorder, and over 47 million adults had a diagnosis of mental illness. As a result of COVID, many states have required closures of schools and non-essential businesses, and states have also prohibited large social gatherings, which have limited traditional social events. Social distancing measures can lead to social isolation and loneliness, both of which are associated with poor mental and physical health. And many of you have probably seen that the Kaiser Family Foundation has conducted an initial study of the mental health impact of COVID-19, and they found that nearly half, or 45%, of adults across the country say that worry and stress related to COVID-19 are hurting their mental health. A final implication for behavioral health that I'll touch on today that due to the impact of COVID-19 is individuals with substance use disorders. Some populations with substance use disorders are particularly susceptible to COVID-19. A recent NIDA study has shown that individuals who smoke tobacco or marijuana, individuals who vape, or individuals with opioid use disorder and methamphetamine use disorder are at higher risk. Since these individuals are at risk for compromised respiratory and pulmonary health, they're likely more susceptible to COVID-19. As a result, would require telehealth support to maintain addiction treatment and safeguard their physical health. These factors can lead to an increasing overall need for behavioral health treatment supported by telehealth and associated policies supporting and clarifying implementation. So with this in mind, we conducted a rapid review of recently enacted telehealth policies for all 50 states and the District of Columbia. We were very lucky that the Center for Connected Health Policy maintains a website that's frequently updated, and they've provided listings of all known executive orders, Medicaid provider letters, and policies, and 1135 waiver Appendix K information. So we reviewed these policies. We reviewed the policies for a number of items. One was implementation dates. As Syra has alluded to before, we're very interested in knowing if these are temporary or long-term policies, and also interested in how generous the state was in allowing retrospective billing for telehealth. In review of the policies, we also focused on whether the state had published specific or specialized guidance for behavioral health treatment, particularly services for addiction treatment and for recovery support services. Another item that we reviewed policies for were payers that were covered. We wanted to see if published guidance was typically for Medicaid only or if it applied to all payers. We also looked at services covered to see if telehealth policies were expanded to include previously uncovered behavioral health services. Professionals were another item that we reviewed, and we wanted to look at how much flexibility was included in state policies and to see if coverage was expanded to include out-of-state providers, peer supports, trainees, or interns. Delivery mode was another policy item that we reviewed, and we wanted to review to see what technology is permissible, so to see if states were following the guidance provided by CMS for Medicare, which, as Syra reviewed before, any electronic or telephone method that allows non-public facing communication such as FaceTime, Skype, or if they had more flexible or fluid delivery modes that they were supporting. Also reviewed quality assurance requirements to see if any published quality assurance, if anybody had published quality assurance requirements, including required documentation, audit, or review. And finally, we looked for any additional special instructions or best practices related to providing behavioral health through telehealth. So before we get into our findings, one caveat, please keep in mind that the review was conducted during the last week of May, and some policies are still evolving. States may be continuing to add their guidance depending on how the state's been impacted by COVID-19 and how quickly the state is lifting social distancing restrictions. So let's review the findings. So with regard to implementation, we found that every state, and the District of Columbia, issued multiple directives on the provision of telehealth services. Hawaii led the charge when they declared the state of emergency and expanded telehealth coverage on March 4th. The majority of guidance was issued on March 13th or closely thereabouts, and that corresponded with the date that the White House declared a national emergency. Some states did provide retrospective telehealth coverage going back as far as March 1st. Those states were Indiana, Nebraska, and Wisconsin that we were able to find. All policies are active for a specified period of time or until the end of the public health emergency. For the policies that I reviewed that were more specific to Medicaid, we didn't see any state that implemented new expanded telehealth guidelines on a permanent basis. With regard to the focus on behavioral health treatment and support, we were able to identify that roughly half the states had provided specific guidance on the use of telehealth in delivering behavioral health services. One state that I'd like to give a shout out to for best practice was New Mexico. They had a very comprehensive document entitled COVID-19 Specialty Behavioral Health Service Guidance. It provided very comprehensive practical guidance for behavioral health providers during the pandemic. It provided reviews of all services which were eligible for telemedicine, requirements for documentation, and prompts for providers when working with clients using telehealth and technology. For payers covered, we found that each state issued expanded guidance for Medicaid coverage of telehealth, and also the majority of states issued executive orders providing requirements for provision of telehealth for commercial payers. They're typically centered around reminders of mental health parity and reminders of various federal regulations. Next, we'll talk about the services that were covered in the policy. We found that most states expanded their list of covered behavioral health services. Some states or some state Medicaid agencies provided blanket coverage of all Medicaid services, including behavioral health. We found that Arizona, Indiana, and Iowa covered all Medicaid services, and Kentucky covered all behavioral health services except residential substance use disorder and residential crisis services. Nevada also covered all Medicaid services with the exception of psychosocial rehab and group therapy, but later they amended to include psychosocial rehab. There were some states that did include peer recovery services, and they explicitly expanded their telehealth policies to cover that. This included Kentucky, Ohio, Oregon, Virginia, and Wisconsin, which for some tended to be the more rural states. One state added the restriction that peer support would only be covered if the provider had previously submitted a claim for that. Kentucky probably provided the most expansive list of allowable behavioral health services covered by telehealth that we could find. All services except residential substance abuse disorder and residential crisis services were covered. As you would probably expect, group therapy was often treated differently than individual services. There were a few states that would cover group therapy. However, typically it was only with the requirement that the service be delivered through video and could not be delivered as an audio-only service. We also reviewed guidance regarding the professionals covered. Most guidance restricted coverage of behavioral health telehealth services to licensed providers, while the majority was restricted to physicians, psychiatrists, psychologists, and licensed clinical social workers. Some relaxed the criteria. For example, Pennsylvania's guidance explicitly stated that telehealth should not be limited to specific provider types, but that other individuals providing necessary behavioral health services would be permitted to use telehealth services that were within their scope of practice. And as previously stated, some states explicitly expanded their service to cover services provided by peers. We also reviewed restrictions regarding licensing within the state. We saw evidence that 8 states included policies to permit out-of-state providers who are not licensed in the state to bill for telemedicine services. There was variation in these policies. Some states expanded throughout the state of emergency. Some states permitted out-of-state providers that weren't licensed in the state to bill for telemedicine services, and there were variations. Some states expanded throughout the state of emergencies, and some covered all healthcare providers, while some only covered physicians. Delivery mode. So many followed federal guidance to allow non-public facing communications such as Zoom, FaceTime, and Skype, but not all. Several of the state policies added special guidance for telephone-based services, and the Alaska Department of Behavioral Health provided guidance on a hierarchy of telehealth modalities, including use of text messages. We reviewed the quality assurance requirements in the documentation and found that several states issued quality assurance guidance, about 18 states in total. The quality assurance guidance centered around documentations, with most stating that documentation should comply with existing administrative rule. Some gave additional documentation guidance. For example, one state encouraged providers to create internal policies and procedures regarding the use of telehealth during the emergency so that all staff would understand appropriate use during the time. A few states indicated that documentation would be subject to audit review, and Pennsylvania allowed providers who were not approved to provide telehealth to do so on an emergency basis using an attestation process. New Mexico provided guidance regarding quality reporting, which stated that telehealth visits would be considered as equivalent to in-person visits throughout the emergency declaration, and that these visits would be counted towards HEDIS and CQA and other performance and target measures. So RTI is going to be very interested in tracking these policies because we feel like they will have big implications for the future of telemedicine and the provision of behavioral health services. The next steps we believe for researchers and policymakers would be continued evaluation of behavioral health services and telehealth policies. In specific, we'd like to see which states will keep expanded services and what's the impact on access to services. Evaluation of the efficacy of telehealth and delivery of behavioral health services would also be important, as well as the impact of the different policies on utilization patterns. Finally, the identification of model telehealth policies would be an important area to review. Now I'd like to turn it over to Lizette, who will be talking more about service delivery and telehealth.
Thank you, Julie. Syra, would you be able to help me with the poll? I'd like to send out a poll and ask a quick, the last quick question to the group.
Yep, it is out. So the poll, as people are completing it, involves what are the biggest barriers to telehealth addiction treatment that you've seen in your organization? All right, I will send the results out to the audience. It looks like the biggest things are consumers are not able to access technology. That was far and away the biggest barrier. And then the next biggest response was that your organization has not yet implemented telehealth for addiction treatment. And then so a little bit smaller, but also listed were concerns with privacy, and then perhaps some other barriers that are not listed. So I'll go ahead and end that survey, and then we can continue on with the slides.
Thank you so much, Syra. So for my portion of the webinar, we will focus on some practical considerations in telehealth delivery. I don't have to remind everyone that the novel coronavirus quickly impacted the world, and the pandemic created a major hurdle in access to care. We have seen the quick response providers were forced to take and the rapid transition to telehealth to meet the needs of clients and to provide the continuity of care. And it opened up a new world of access, but it also brought some challenges with it related to privacy and ensuring trust and confidentiality. And these have important implications for how providers deliver addiction therapy in these conditions, but also as we move forward towards our new normal. Syra gave us some great background on telehealth, and Julie gave us, a good look at some of the evidence. And I want to add a bit to that and first talk briefly a little bit more about the evidence for addictions, what we know and what we still don't know. I'll spend some time talking about the telehealth landscape pre and post COVID from the perspective of privacy. I'm very interested in sharing with all of you what the post-COVID privacy issues have revealed about the provision of telemental health in our country and how lessons learned from the last 3 months highlight the needs for our clients and especially our most vulnerable patients. And I will end and close with some specific clinical recommendations for addictions, telehealth that can easily be applied to other telehealth settings. So before COVID, what was the appeal or the need for telehealth in the addictions? Well, it was a very big one. Individuals with addictions and substance use disorders we know experience one of the largest gaps between treatment need and treatment utilization, with only a minority of clients actually receiving treatment. Telemedicine has been shown to be a promising approach to expanding access to care. But as Julie mentioned, research has shown that the studies are very limited. There have been numerous studies and reviews examining the effectiveness of real-time video conferencing delivered for anxiety, PTSD, depression, but considerably less for addictions. And as Julie mentioned, telehealth itself is not new, And to date, we only have 13 focused studies on addictions, and these are focused on nicotine, opioids, and alcohol. Most studies show telehealth interventions are associated with high acceptability, high client satisfaction, and are an effective alternative, especially when access to care is limited. So we know for the most part it's working, but there's just not enough funding behind it. And in terms of questions that remain, we need more information about sequencing and research on how patients of color and in diverse settings respond. Most of the research I just discussed was primarily conducted with white middle-class samples. So there's the evidence. And so going back to privacy and ensuring confidentiality, again, my focus here is very practical. So when thinking about delivering telehealth, this is going to fall on what providers do and their telehealth capacity. For most providers, they didn't receive formal training on how to work in the telehealth space. They're trained on how to work with clients face-to-face. So the art of rapport has a different feel and a different flavor to it when connecting via video. Providers need technological competence. This is much more than just proficiency with the platform. This has to do with making informed decisions that reflect an understanding of the patient's preferences and their experience using technology. For example, how to responsibly use the technology they have selected or have been given to work with, and a thorough understanding of its functional knowledge, its strengths, applications, and limitations. That has to be at their fingertips. So of course, this has implications for privacy, confidentiality, data integrity, and security. They also have to be familiar with the legal and regulatory issues we've been discussing. Competence here is related to adherence to relevant federal, state, and local laws, and right now they're constantly changing. They have to have experience and competence related to mandated reporting, informed consent, documentation, and legal technology. Providers also need, looking at my second point here, providers also need telemental health competence. This is more than just adaptations of our interventions for video. This has to do with the ability to establish a virtual environment telepresence. This involves applying appropriate techniques to maximize a therapeutic atmosphere in both physical and virtual environments. We're trying to approximate here an in-person relationship, foster spontaneity, and minimize distraction and interruptions. Face-to-face works because it allows providers to track micro-expressions, their clients' postures, and other details like personal hygiene and care. All of this is very different in a telehealth space. And of course, we know from our own virtual work, there are always going to be some technological challenges, and being able to handle those and easily transition back to a therapeutic space is not easy, which is why some therapists have shied away from this modality. So this brings me to my last point here, which has to do with nonspecific therapeutic factors. They are the glue here. Nonspecific therapeutic factors simply are elements in a therapy that contribute to improvement, but which are not specified in the theoretical delineation of the therapy. So for example, nonspecific factors refer to dimensions shared by all psychotherapies, and they include things like strong rapport, therapeutic alliance, trust, and patient engagement. I mention all of this because developers of telehealth treatment protocols with the best intentions focus a lot of their attention on ensuring that telehealth adaptations adhere to the theoretical components of their intervention. And so the focus has been really heavy on the fidelity to the theory. I can tell you now that none of those interventions are going to be as effective in the telehealth space without these three components I just mentioned. So before COVID-19, not all providers had experience or capacity in working in the space. Providers using telehealth had conceptions that patients dislike teletherapy, they found it too impersonal or difficult to navigate. And providers who used telehealth pre-COVID were also very different. In fact, this is considered like a niche industry. These providers were already more open to the technology either because of the need or genuine interest. All providers are very well aware, though, that the therapeutic stance and rapport can disappear quickly, helping a client troubleshoot, for example. So these two issues always continue to come up as some of the most important for effective telehealth provision. Post-COVID, though, is a different story. So here's some post-COVID telehealth considerations. I don't know who to credit this with, but I've heard it several times. It took a pandemic to prove the value of telehealth to the American healthcare system. The pandemic created a major hurdle in access to care. And in response, many organizations have relaxed organizations. We've heard about this, we've talked about this. Many behavioral health providers have been quick to embrace telehealth solutions in order to make sure that they continue caring for their clients and, frankly, to ensure that they had work. The speed of adoption presented several implementation challenges as processes and technology solutions have not been put in place, and so people had to act quickly. Not only is it the responsibility of providers, counselors, and facilitators to protect information and identity, but it's also critical to the success of these therapeutic efforts. If your client has concerns regarding confidentiality, privacy, and security, it will reduce or outright eliminate the trust and safety that they feel. That psychological safety is key for an effective session. And some challenges related to privacy that providers with limited experience and capacity for telehealth are listed here. So quickly finding a safe place to participate with sheltering in place, concerns about new telehealth platforms under relaxed regulations, confusions about federal confidentiality regulations, and possible decreased therapeutic connection with some telehealth platforms. With all of that, it does seem like Americans quickly adapted to telehealth. It's not easy on the providers who didn't use this before, and it's not for everyone, but the COVID pandemic revealed that people of all ages can quickly adjust. The COVID pandemic also revealed a harsh reality that was always there, but really amplified in quarantine. People from vulnerable populations are exponentially more vulnerable now. Not all patients can get online, and in-person treatment options quickly dwindled with lockdown orders. Safety net clinics were hit especially hard. And this has had a direct impact on service provision for addictions. We see this with clients from both urban and rural settings. For telehealth, two main issues that emerged are connectivity and space privilege, and Julie talked a little bit about some of these. I want to expand on them some more. In terms of connectivity, we know telehealth has a lot to offer rural regions, but connectivity issues are still getting in the way of technology's ability to reach its full potential in the U.S. This is also happening in urban settings. With many working from home, we cannot assume our clients and patients have sufficient bandwidth or decent connectivity to be able to take a high-quality call or video session. We also cannot assume this or impose this on them. Space is another issue. We work under the assumption that clients have ample space and private areas to speak freely. We also assume that clients are okay with us now having access inside their homes. To foster trust, we must openly and graciously help clients with these possible barriers to care and ensure comfort in their sessions. I wanted to end with some recommendations when working with clients in this space. This information can be useful from a practical clinical perspective, and these are also some of the lessons we're learning that are coming out from our interviews with providers, both that are seasoned telehealth providers and the ones that I've just learned in the last 3 months. These recommendations can be addressed before, during, and after the session. Providers can take action by ensuring that all telehealth privacy concerns are addressed with clients before offering services and recovery supports. Ideally, this should be done before the first session as much as you can and whenever you can. In every session, communicate with your clients that their privacy and safety is your top concern. If the privacy situation changes during the session, reschedule if possible. Additionally, although audio-only interventions may not create the same level of relationship building and belonging, providers should encourage clients to choose a modality with which they feel comfortable and work from there. Audio-only communication may be the first step towards video interactions, and right now, telephone visits are covered. Before setting up the session, spend some time trying to brainstorm with your clients. Don't ask when are they available. Instead, ask when are some good times that they'll have the most privacy. Can they take a call from a car, or take a walk? And after the session, encourage clients to spend some time reflecting post-session if necessary. Many clients are reporting increased access, but missing that post-session drive or ride home where they can reflect on what was discussed. We don't know what's going to happen after this health crisis subsides. What we do know is that millions of people in this country have jumped in, and telehealth capacity has expanded incredibly for both providers and users. What an opportunity. The hope is that this rapid expansion helps everyone from providers to policymakers and even consumers to consider this powerful modality. For anyone interested, I have detailed handouts with all the content and resources in my portion of the webinar that are just more practical and clinically oriented, and those that include information about privacy when working with groups, which is huge in addiction, but I didn't have much time to address. With that, let's check the chat box for some questions.
So there were a few questions. This is Tyra Hawke again. One thing I wanted to mention before we get into some of the questions is there is an interim final rule from CMS that will address some of the proposed changes that will be retained after the pandemic. It's still in the comment period, and so we will be sending out a link to that so that people can take a look. We'll send that out after the webinar, and so folks can see what some of the proposed changes are, and then it remains to be seen if that rule will be made final or if there will be some other changes. That does only address CMS as a payer, and so there are some private payers that may or may not follow suit. So I just wanted to address that before we move on to some other questions. So that's one. There was also another question about whether or not the surveys that you all did would be part of the recording, and they won't. They're just live, so just to take a temperature at the time. And then in terms of some of the other references, those will be in the handouts and also on the slides. So those are a couple of the questions that we've seen so far. There was a question about, I saw one in the chat about if it was possible for clinics to deny service if they're not able to use secure technology. So for example, if a patient could only use a consumer-facing technology. So right now, and this is just in the period right now, it is allowable to use consumer-facing technologies. Typically, it is not allowable to do that. And so consumer-facing technologies, when I say that, what I mean is things that are not secure and they don't follow the security provisions under HIPAA. So the data transfer is not necessarily secured, and it's more easily able to be hacked than perhaps some others. Now you don't want to use those if you have another option, but the reason behind allowing those to be used during the pandemic was so that people could receive service. So if there is someone who can only, if you have a patient who could only use FaceTime or Skype, and perhaps a phone call won't work and the other alternative is them coming in, and you don't necessarily want to do that, then it is allowed to use FaceTime or Skype, or those are two examples, but whatever the consumer-facing technology might be. Of course, if you have a technology that does meet the requirements, then it's better to use that because it's secure, but it is allowable. So that's the answer I wanted to give there. So Lisette or Julie, were there any questions in the chat that you wanted to address? While you guys are looking through, I see another one here that says, where can someone get training to promote telehealth services? So I wanted to address that. And one thing about training, that there's a lot of different things to be trained on, and I saw a few questions that were related to training. There's training that has to be done about technology, about best practices in providing services, and then also how do you learn more? So there's a lot of training that's out there, or that's needed. In terms of what's out there, there is a whole national network of telehealth resource centers. And so those are funded by HRSA. And that network of telehealth resource centers has a number of regional organizations which are designed to provide training and technical assistance about telehealth. And so I would encourage you to look for your own regional center and reach out to them. They all have websites, and they all have a variety of different types of resources. And they offer webinars, and they also offer technical assistance. And so those resources and everything are free. They're funded by the government, and they're constantly being updated. So I would start with your telehealth resource center for training, and then from there, if you need to have additional, they can probably help direct you.
Hi, Sarah. This is Lisette. I'd like to answer the question related to how academic programs can help train prospective providers to provide effective telehealth tools, strategies, interventions. My recommendation there is to do something similar to what was done in several programs across the country and the world around evidence-based practice. Little by little, these were integrated into the curriculum. And I think with telehealth, it probably will be a little easier in the sense that once we start getting more research in this area for specific programs, those components can be almost seamlessly weaved into the curriculum for different programs. I think that would be the best way. And I think after COVID, we're going to see a lot more of that. There was also another question related to an increase in referrals, whether or not after, post-COVID, we're seeing an increase in substance use disorder treatment from other programs such as Head Start, child welfare agencies, primary care. I'm not sure with all agencies, but I know here in North Carolina there has been an increase. It's very difficult still because it's even though there's an increase in the need, services also have gone down. So we're tracking that and seeing how that moves during the pandemic.
Great, thank you. I also saw another question around small and independent, maybe smaller medical practices. So there was a question around, what are some ways that maybe practices that don't have a large IT department or don't have as many resources could expand their telehealth capabilities. And I wanted to call your attention to a resource. Actually, RTI worked with the state of Maryland to develop the Telehealth Readiness Assessment Tool. And so what that is, it's an online tool that will take providers through a questionnaire, which was evidence-based. And you can go through the questionnaire and get a score and also look at guidance across these dimensions. And so we will send out a link to that, and it's called the Maryland Healthcare Commission Telehealth Readiness Assessment Tool. And the whole purpose of that was for independent providers to be able to take a self-administered short tool and then figure out what they have to do next to either promote telehealth uptake or expand their current telehealth program. Now, we developed this for the state of Maryland and with the state of Maryland as a partner. However, this really would be applicable for independent practices throughout the country. So I saw there were a few questions in the chat around either a small practice or a solo practitioner or someone who's brand new, and I would highly encourage going there as a way to start. And it's there's a paper-based option and there's an online option. So no matter which way you prefer, there's a way that you can go ahead and take that and see what to do next. And I did see another question in the chat around if there was a local technology company that would provide telehealth tools and technology. And what I wanted to say is that there were a couple of questions around technology provision and what vendor to use. So we are researchers, and as such, we've seen telehealth implementation using a variety of technologies. Now, we probably are not in a position to suggest one versus another. However, I know that some of the telehealth resource centers maintain lists of vendors that they've used and vendors that might be good for different purposes. So I would encourage you, I know I said it already about the National Consortium for Telehealth Resource Centers and then your regional one, but I would encourage you to both go to the national one and then click around for some of the regional telehealth resource centers, and they will help you. They will help you not only decide on a technology, but also to think about some of the things that you might want to consider when you're picking a vendor. There isn't really a one-size-fits-all, but rather you have to consider what's the best vendor for what you need. And I see another question about restating the resource for Maryland. And again, it's the Maryland Healthcare Commission Telehealth Readiness Assessment Tool. If you Google those terms, it'll come up. I've Googled it before, that's how I know. And then you can go ahead and you can take that online, or you can download the PDF.
Sarah, I saw a question about how we are evaluating the effectiveness of telehealth that I could address.
Okay, great.
So, yeah, the way studies definitely do that, and the way we've done it ourselves in our own work is, for the most part, is comparing it to face-to-face interventions. And one of the challenges with evaluating the effectiveness of telehealth is our assessment measures. And oftentimes it's a little bit more challenging to do it in a telehealth space, but at RTI we've developed great ways of finding ways to reduce our instruments to be able to reliably, in a valid way, capture the critical information about if a patient is improving and areas of their functioning in which they are making progress, to be able to evaluate the efficacy of these interventions. We know from the research that for the most part, most interventions studied, there's a really high rate of patient satisfaction, but now we have to move and more carefully examine if our patients are improving in terms of the symptom change, in terms of functioning, and there's a lot of good research out there, but a lot more to be done.
And this is Syra. Just to add to that, in terms of evaluation of telehealth, a lot of times there are a number of different types of outcomes at play. So when looking at evaluation, you have to think not only about outcomes, but what are some other unintended consequences. And unintended consequences can be good or bad. So for example, you might find that you have improved treatment retention because of telehealth, because people don't have to travel. Or local organizations, so for example, a rural hospital might find that they have increased other services, ancillary services, because they don't have to necessarily send the patient away and have them do all those services away. So that might help with financial viability for small rural health systems. So there's a couple of different things at play. All right. I think we have time for maybe one more question. So there was one question I thought was very interesting about the possibility to set up mini stations or set up kind of ancillary settings and reaching out to neighborhoods. So maybe if there's a community, and I'm kind of interpreting that to mean that perhaps like a community center or something like that. And so there are some places that have adopted that sort of model and provided telehealth pods, if you will. So that's certainly something that's been happening, and I think it would be a great thing for people to consider and continue with. And then there also is another, someone from SAMHSA pointed out that in addition to the telehealth resource centers, SAMHSA also has regional addiction and mental health technology transfer centers across the country. So those provide specific trainings for telehealth, specific to behavioral health. So if you go to SAMHSA's website and look up regional addictions and mental health technology transfer centers, you'll be able to find those. So between the SAMHSA resources and the HRSA resources, there's a lot of different things that you could use. And also the Maryland Telehealth Assessment Tool. Those are three great resources that will provide education, training, and technical assistance. So I think we have one more minute, and we do want to give enough time for people to do their CMEs. So that's on this page here. So you can, I'll just sort of leave this here, and then you can stay on the platform, and you'll be directed to a landing page, and you'll be able to complete your CME or your continuing education rather from there. If you've not done a webinar in 2020, you'll have to make an account first. If you have, then you can just go ahead and log in. And with that, we would like to thank you for your time and attention. Thank you so much for coming, and have a great rest of your day. Bye all.